Hey guys, my name is Tyler Miller. I'll be covering the objective examination today. So without further ado, let's dive into it. All right, so what is our objectives today? First, we're going to define the role and the purpose of the objective examination. We want to clarify the idea of what a comparable sign is and also the hypothesis generation that we'll be performing. We want to recall the SENS model and how it drives our objective examination. We want to explain the role of screening and its purpose in the objective examination. We want to examine the procedural flow and break this apart and really see how it develops throughout the objective examination. So first, let's talk about the role. What is the role of the examination? Well, it's using selective tests, usually based on a hypothesis generation. It's going to be with regard to the symptom mechanism, the sources, those secondary things that are going on, and also any contributing factors that are occurring as well. The emphasis should be on reproducing that familiar pain, that pain that brought them through the door. This will help confirm our diagnosis, and also we can use that in a test, treat, retest scenario. At the end of the examination, before we go into treatment, we should have a confirmed hypothesis. We should have 1 to 2 comparable signs and also a guidance on how are we going to treat this patient. So the hypothesis, this is made through sound clinical reasoning, and it's made at the end of the subjective examination, not throughout the objective examination. It should express the sources, the contributing factors, any precautions or contraindications, and also the management of this. Keep in mind, too, that the hypothesis doesn't necessarily have to be anatomical. It can also be treatment-based as well. We see that this is extremely appropriate for the lumbar spine. So comparable sign, this is the crux. This is what brought them through the door, their pain, their familiar sign. It's truly what we're looking at to help confirm or not confirm our diagnosis. Now, of course, when we're poking, prodding, movement, etc., we have some pain. Any pain that might be painful or abnormal, but it's not that comparable sign. This is just simply just a joint sign, or also known as discordant pain response. The key with a comparable sign, or it's also known as concordant sign, is it needs to be measurable. We need to make it objective as possible. So a joint sign, this is not your comparable sign. This is any abnormality found in clinical examination. You just kind of want to note it and move on. It can help determine contributing factors. It can definitely help bring in regional interdependence, but we need to stay away from making assumptions based on joint signs. Always remember, correlation is not causation. We don't need to lose sight of the forest by staring at the trees. And unfortunately, joint signs can kind of lead us down the wrong path. So note them, but don't hang hats on them. So the principles of this assessment. First, begin all your range of motion in neutral. As we know, posture can play into how things are loaded. Unless we start constantly neutral, this can throw us off quite a bit. We want to make sure that we're not examining through clothes. The skin is definitely in. It's important to clarify throughout the assessment, is this patient sign, and are there any changes that are occurring? Why that is so important is, pain can change slowly throughout the measurement. So if we're not checking after every single thing we do, we could actually lose sight of the pain and it can increase, but we have no clue what brought it on. And finally, motion's not cleared unless overpressure is performed. We must rule out above and below to make sure there's no contributing factors there. So the review of the SENS muscle. This truly helps kind of guide our objective examination, and it helps determine how willing are we to provoke these symptoms. It's going to help us select the amount, volume, and vigor of the selected test, and even help guide our treatments. Keep in mind that you never, never, never want to over-examine the irritable, and also you don't want to under-examine the non-irritable. You want to use the SENS to also guide your procedural flow as well. You want to progress from the least invasive and least vigorous to the most invasive and most vigorous. A good example is this is oftentimes we might want to check active range of motion, but the patient talks about bending over, quickly sets them to an 8 out of 10, and then it goes, stays that way for a couple hours. Generally, we don't want to start off with that active range of motion. We might want to go to a different route or an unloaded position. The key is let the SENS model guide your ordering. All right, so here's the procedural flow. It's listed to your life. This is a guideline, of course. Our ability will help define which we do well, but for the most part, this is generally the flow and the order that we do. So observation. This is simply to give you some general information, just give you a general idea of kind of what's going on. You want to look at their posture. What's their gross movement? What's their willingness to move? How do they open up the door? How do they walk in? How do they sit down? All gives you really good ideas and kind of starts getting your mind going of what might be going on. Also, just not even from a journal, but just look at a local. Look at it, with calf pain. Is there any skin changes? Is there any swelling? What's their bony alignment, wasting of muscles, scars in the area? What is just kind of going on in the area? Again, don't make assumptions, but let it kind of start giving you some pieces to the puzzle. So screening. We need to perform a lower or an upper quarter screen with every single patient. This truly helps kind of look at the body from a regional interdependent standpoint. Gives us some ideas of what we possibly need to clear, or it does help us clear. And also it does screen for red flags that may warrant a referral from the therapist. For all extremities, screen up to the spine. A good assumption is the spine to prove otherwise. So how do we do that? Well, first you want to take your general motions, and general motions, you want to do combined motions, and then you want to rule those out, combined motions with overpressure. And then if you still think something might be going on, your paddles are perfect in this way. So screen through motion, screen through segmental mobility. If you can't rule it in those two, then you can cross it off and move on. So can lumbar truly disguise itself and make itself look like something from the lower extremity? Well, absolutely. Here's a picture of a typical lumbar facet. The L3 to S1 can absolutely referring to that interior thigh. That can mimic a quad strain, tight hamstrings, IT band syndrome for the L2 to S1. All those things can refer, and it can be solely in that area. So keep in mind that the lumbar referral can definitely mimic typical musculoskeletal problems, but the way that we can tease this out is through screening the lumbar spine. Next is the disc referral. It can go down. Oftentimes you can see this and you can show it, and it definitely is relevant, but sometimes we need to still screen out to see if it truly is coming from the lumbar spine. All right, what about a nerve screening? Is this required or needed? A good rule of thumb is any symptoms below the acromion or the gluteal fold will require a neurological screen. So how do we do this? Well, the first is our big three: reflexes, myotones, and dermatones. So for reflexes listed above is generally the top three that you would do in the lower extremity, and also the three that you would do in the upper extremity with the sensitivity and specificity listed above. Myotome, again, this is with the lower extremity to the left and the upper extremity to the right. For the upper extremity, the sensitivity and specificity very well supported, though it's quite unknown for the lower extremity. Keep in mind when you are doing the lower extremity, sometimes those muscles are big. We're not going to pick them up. You can make it a little bit functional. So for your L5, walk on your heels. That's one. Walk on your toes. For our younger population, single leg, sit to stand, all those are really good myotome screenings that just go beyond simple testing of the muscles. And then finally, dermatones. We know that the research is kind of iffy on dermatones, and their variability can be very wide, but we should not throw the baby out with the bathwater. Definitely look at it, definitely screen it, and just look for a difference side to side. All right, so upper motor neuron testing definitely needed when it's appropriate. Helps screen out some red flags. Babinski, Clonis, and Hoffman are the big top three that can help us rule out if anything is going on. Some other additional sensitive tests is any type of nervous system testing. So your upper limb tension test, your slump test, your straight leg raise, and then finally pain pressure threshold. And this can go above and below and really show if there's maybe some possible sensitization or central sensitization going on. So functional demonstration test. This is often coming next after a screen. And what you want to do is this is the show me. Is there anything that you can show me here and now that provokes your pain? It should be based on your irritability, because this is definitely the thing that's going to bring on some of their symptoms. But remember that this test serves many, many functions. One, it's a phenomenal comparable sign. It can truly do great if you can make that measurable to that patient and show that you truly you are listening and care what they're coming in for. And finally, you can use it too is from a differentiation or a symptom modification test. Say the person is doing some overhead reaching and that brings on their pain. Well, right then there, give them a scapula guide, give them a posterior glide on the glenohumeral joint. This can give you more information in your objective examination to truly help you let you know what might be going on and how to proceed with treatment. Next is our motion. Active range of motion, passive range of motion, overpressure, all key when we're looking into joints. Also, do not forget to go into the quadrants of those. Resisted range of motions, these should be performed in your cardinal plane. They're going to help determine any type of deficits or comparable signs going on. Keep in mind that if you are listening that this is a muscle strain or tear, resisted range of motion should be painful and should be painful in a couple of multiple angles. So if you're only, say you were having a biceps and we think we have a bicep strain, it's painful at 90 but not anywhere else. It might actually not necessarily be the muscular tissue, it might be something else going on. Palpation. The simple with palpation is first ask, would palpation help confirm my hypothesis? With bursitis, plantar fasciitis, Achilles tendonitis, all those really truly can be helped and confirmed by palpation, but oftentimes this is something that's really not a good comparable sign, and it does not lend itself very good to a test treat retest model, and it's very, very subjective in its findings. But also know that you do want to do some general palpation as well. Bony landmarks is great, temperature, swelling, arterial pathways and nerve pathways. Those are two things that is often overlooked that can give you so much of an insight to what's going on with this patient. Joint assessment. You must assess the joint through the estimated irritability levels, meaning if we're going into the joint, do we want to jump straight up to a grade 3, the most aggressive kind of grade there is? No, we want to start with straight up with grade 2, go to grade 1, go to grade 4, go to grade 3. Based on that irritability, we might want to, say the lumbar spine, we want to go all through grade 2s, L1 through L5, and then start building up a little bit more. Things to look about, does this bring on the patient's symptoms? And also, look for resistance as well. Something as well with joints that we often forget is, change it a little bit. If you're pressing on, they're saying that's their pain, and you notice that you got a little bit of muscle in your hand, try to shift it over. Make sure to change a few angles and see does that affect it, and so that way you're gaining a little bit more knowledge about what's going on. So special tests, special tests have their place. Their place is not on the top of the mountain, but it does give you more pieces to the puzzle. Listed below are kind of guidelines for what is the best special test. Remember, there's no fatal flaws in design. That all tests they have issues with them. So you want to look for your positive likelihood ratios, your negative likelihood ratios. Sensitivity definitely needs to be a 0.9 or higher. Your quadrants needs to be at least 10 or higher. It needs to be a test that matters. If you think that patient has something going on, you want to do a special test, does it test for that, or are you just throwing more tests at the patient? Most special tests are provocative in nature, so we want to keep these very, very limited and only use them when they give us some idea of what might possibly going on. So in the summary, remember the objective examination is using deliberately selected tests. Do not test for test's sake. You need to have at least 2 reasons of why you're going to test something in the objective examination. It needs to be based on your hypothesis generation. If you think this is, a dyspathology going on, you need to be able to be doing your test to help confirm that, to also look for any of the other sources that might be kind of going on and any contributing factors as well. Your irritability should guide that order of that procedural flow. Irritability is so important what we do. It helps prevent us from getting false negatives, false positives, and also helps the patient in a sense not get so flared up that we can't really get them out of it. So again, make sure that irritability is guiding you. You want to look for 2 or 3 comparable signs. Sometimes we find that one and we're done, but really there might be more than that. So it's really good to at least have 2 and try to make them as functional as possible if you can. And then finally, you're going to use those signs to use in a test, treat, retest. Thank you so much, guys, for listening to this presentation on the objective examination.